Thank you very much. I'm going to talk to you about management of large submacular hemorrhages. And when we look at hemorrhage occurring subretinally over the macular area, the classic way to treat it is usually with anti-VEGF gas positioning, and it works well for a certain variety of cases like you would see here. And over a period of a few weeks with the tamponade, the hemorrhage would go to the periphery and clear off. But doesn't happen that easily with a thick blood like this. So you need to differentiate between the type of cases that you come. If it's a more flat looking blood, you could resort to those things. But if it's a thick collection, that almost always leads to something like this. If you just keep waiting on it, sitting on it. This is the other eye of the same patient that I'm showing you a video of. So in these cases, I surgically go in and do a large retinectomy in the periphery. So first remove the hyaloid as far as possible, because you're going to do an invasive surgery and you don't want PVR and other things setting in. So stain with triamcinolone, make sure the hyaloid is identified well so that you can do a good removal. After that, just to test if the blood moves, put in some PFCL, but as you can see, it is so rigid, hard, clotted that it doesn't. So start with the peripheral retinectomy, almost about 200 to 270 degrees based on the size of or extent of the hemorrhage which is present. So diathermize mildly some of the larger vessels in that area and then cut it. Then remove the PFCL and then evert the flap from the retinectomy, just like you would see a giant retinal tear. That allows you a direct view, direct access to this thick clotted blood, which otherwise is extremely difficult. So you make sure that you get access to this whole plane. Gradually with the forceps, you can atraumatically take the retinal flap away. You could use bimanuality, you could use chandeliers. Multiple ways could be done to atraumatically get access to this hemorrhage. And as you can see that by moving the cutter, all that hemorrhage gets dispersed, removed. The thicker part takes a little while, but usually today's cutters can remove all this clotted blood quite effectively to a large extent. So you can see that slowly that whole area clears off, that whole thick collection of blood which was there. And once you're sure that is gone, then you revert the flap back with using the perfluorocarbon, just like a giant retinal tear. And now you can see that the retina is going back and there is that thick collection is gone. All you see is some pigmentary loss, which obviously is going to be there because that's where the whole membrane which had triggered the whole episode was, and then you treat it like a giant tear. So this is how it looks like in a month's time. I first presented this in 2016 at the Whale meeting, and then we did a lot of cases similar to this. This is another one, a large one, thick one, which required a similar sort of management. First remove the vitreous, especially stain it with hyaloid, because these are cases where you want to make sure that everything is clean, because any residual vitreous with large retinectomies, with blood, all this invites a lot of PVR in the long run. So do the same process, peripheral retinectomy in relation to the quadrants of the hemorrhage. So you customize it to the area where you see the hemorrhage and go a few clock hours beyond, because you need a bit of relaxed area for the eversion of the flap. So the same strategy we use, get access to the plane directly, and you can see that bimanually I'm trying to evert flap with one side and remove, and then put the retina back like a giant retinal tear. So these are patients who do recover back easily about 636 to 618 vision. Of course, they have a central loss of receptors which is going to be there. And then there are these slightly smaller but thicker sized hemorrhages. So this is a separate variety which are not extending to the periphery but are thick and not very thin. So these are cases where I do a posterior smiley retinectomy, not an extensive peripheral one, and then remove it just like we used to remove the small subretinal hemorrhages in the past. That is an art we've given up earlier when the anti-VEGFs came, but I think it still helps us for cases like these, because these also end up with thick scars otherwise, these kind of membranes. So here also do a good vitrectomy, and then as you can see, I identify this area just within the vessel arcade, and do a very mild diathermy, and then bring my cut rate down from 7,500 or a 10,000 to just 100 cuts a minute. So you can imagine the cutter would go just cut, 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 cut. So it's in your control. It works like a scissor. It's easier to do this with the cutter like this rather than use any other instrument. You could use a scissor also if you like, but it's just that these cutters work almost as good as a scissor, and with a very low cut rate you can control it like a scissor. And then it gives you access to the plane like that. The smiley shaped incision actually gives you a larger surface area, and you're also following the vessels. And then once you engage the whole mass of the hemorrhage membrane, which is usually coagulated onto itself, it with a gentle rocking manner would come out. So you can see that whole, you're engaging it with high vacuum on one end, and then very gradually just getting it out, and it delivers as a whole, this whole tissue, and then of course eat it up with cutter. So what remains is a smiling macula at the center, and then do a very mild laser to that edges, and then put gas and positioning. So this is what it looks like on follow-up. You can see the fovea is not as bad, and you see the incision on top, because during surgery you saw it at the bottom, but it's basically superior, and the fovea is pretty healthy. This is how it looks like. This is a case I just did 1.5 months back, and other eye of the patient already had a disciform scar with a similar hemorrhage, and the right side is what the patient presented with 2 days of history. And we posted for surgery with a similar, exactly the same kind of procedure. And once again, after doing the whole vitrectomy, hyaloid removal, plan the incision in this area. So you do it, the placement of this is based on the bulk of the blood and where you can easily access it ergonomically based on your own ergonomics of which hand you use or which instrument you prefer. You could change it. So this is what I follow, the same principle here. And then once you have that incision, and of course the size also you have to slightly consider in terms of the extent and make it accordingly. Otherwise when you bring it out, it could sometimes enlarge or expand. So make sure you have a well relaxed incision when it comes out, and the whole complex delivers. And so the membrane as well as the blood would all come out together in toto with this. The fovea behind is clear of the blood now. This is the 1 month follow-up. You can see that there is pigmentary damage to the center, but which is part of the process which is there. You cannot do away with that. But otherwise, these people gain back reasonably good vision to move around quite soon. Otherwise, it takes a lot of time with all that scar and the central scotoma, which can be quite cumbersome. A few different cases. This is a case I took for doing a large retinectomy, but when I went inside, I saw large choroidals also once I cleared up the vitreous hemorrhage component of it. And because of the choroidals, I resisted doing a large retinectomy, because then it would have been too aggressive and may have caused more inflammation. So in this case, I just did subretinal injection of air, and then did air fluid exchange. How Tamer Mahmood, I think, had presented some cases like this, and left it with subretinal air bubbles and an air-filled eye. And because of the choroidals, if I make retinectomies, it may cause more bleeding or damage. So I had to change my plan inside, and it did gradually clear up centrally. This is the early pictures after a week or so, and so this is something you need to modify if you have a situation like that you also see extensive choroidal activity. Then maybe you should not do a large retinectomy in those cases. So these are some of the surgical steps that I use, customize it for a few set of patients which have a thick hemorrhage over the macula. Sometimes it's extremely large, which warrants a large retinectomy, and sometimes it's within the arcades, but it's very thick, and I don't think will come very easily with the use of just gas and positioning. Thank you very much.
Thank you so much, Manish. This actually,
Yeah. Yes.
yeah, this is actually Subhendu's territory also, I'm sure. He can give one his own presentation on this.
Yes.
But yeah, so Manish.
Yeah. So basically, you're right. So you could use a scissor also, but these cutters are so fine with, and you go with a small cut rate, and you're almost going in obliquely that technically it just makes it very simple instead of trying to maneuver a scissor. But you could do a scissor. You're right. I mean, you might save a little surface area. Yeah.
So Manish, the excellent videos and compelling case, like
Thanks.
you would make everyone believe that I can go in tomorrow and.
Actually, all it does is disperse. I think it just takes up, it just occupies a certain space, and because vitreous cavity now also has an air bubble, it's air filled, so you give prone positioning, so that is pushing. But just with the stuck up blood, sometimes it's not able to move it. While here the bubbles are also by themselves moving. So Tamer Mahmood has presented a series of these cases. Of course, he also uses TPA along. Some people use So various people use mix and match. I've not had a great experience with TPA, so I'm not a huge fan of TPA. It almost always brings about a vitreous hemorrhage afterwards, and you might have to go back in again at times. So I prefer
So
clearing it.
that's the big question, Manish, in the sense, at least for some of those limited within the arcades,
Yes.
there have been multiple publications of just intravitreal
Yes.
TPA. You do get vitreous hemorrhage, you can clear it out later on, but you don't have to manipulate subretinally. And there are some cases where you may want to give a subretinal TPA, either just subretinal TPA and air and leave it, or drain it, give it some time to liquefy and then drain it in the same surgery. But at least the big ones where you had kind of exudative hemorrhagic detachment, large ones, you have to many times drain them out. But the ones which were limited within the arcade, I don't know, Dr. Vishali, what are your thoughts?
Subretinal TPA with air, we are doing it a lot.
Yeah, so that's something less dramatic.
Yeah.
I used to do.
Everybody cannot do it like Manish.
There's so many ways of.
We are complimenting.
Everybody
They're
has their own
He's an
modifications,
artist,
like
yeah.
subretinal TPA or subretinal TPA plus anti-VEGF plus air.
That's right.
Non-drainage technique, and if it is larger enough, so you can do the retinotomy, 2 paracentral retinotomy that can remove the
even
blood,
BSS
but not
works.
not the CNVM part.
Actually,
but you
before
can do the
era
peripheral
of
retinectomy.
anti-VEGFs, we've done so many subretinal membrane removals that
Yes.
this is
You're
actually just
tempted.
an extension of
Yes.
that. It's rightly, Earlier
Is
the better.
also-
It
also,
only
yes.
works in the first few days to a week, I think.
14 days
After
is
that,
the
it's
usual guideline.
Not
Yeah.
beyond 4 weeks.
earlier the
Before
better.
fibrosis.
Yeah,
Once
yeah,
there is fibrosis.
Yeah.